Hi, everyone. Thank you so much for inviting me to speak to you today. It's really an honor. And let's see, hopefully you can see my slides. Yes. So the title of my talk was originally Equity and Inclusion Challenges in Pediatric Transplant. But I remain an optimist, and so I'd really like us to think about the opportunities as well. So the objectives today, first, I just want to spend a little time making sure that we're all talking the same language. So we'll talk a little bit about some definitions of equity and inclusion, and also why these things matter in transplantation. Then we'll talk about some strategies to achieve equity and inclusion across different levels of our transplant ecosystem, including recent efforts made by the United Network of Organ Sharing and the OPTN. And then hopefully these things will promote some discussion, and we'll have some time for Q&A, really to think about how transplant centers can partner with patients and families to promote equity and access and outcomes. So first, let's talk about the definitions. So what's a difference versus a disparity? This may be something that you hear us talk about. So a difference is, I have brown eyes and someone else may have blue eyes. This is just a difference, but it becomes a disparity if it creates a difference in access to health outcomes. So disparity is defined as an avoidable difference in health status or health outcomes between groups who differ in social and/or demographic characteristics rather than just physiology. So if I only transplant people with brown eyes, that would be a significant disparity. So equity versus equality, those are other terms that sometimes we flip around a little bit. So equality is the state, quality, or ideal of being just, impartial, and fair. That means if I say, I have 100 people in a room and I say, I'm going to give you shoes so that you can walk a mile. But if I give everyone size 10 men's shoes, that's not really giving everyone the same access to walk the mile and with the same comfort and maybe the same speed. So equity really involves trying to understand and give people what they need. So giving everyone the size of shoe that would fit them. And then inclusion and diversity. So inclusion is the practice or policy of providing equal access to opportunities and resources for people who might otherwise be excluded or marginalized, such as those with physical or mental disabilities and members of other minority groups. So you can see here a group of people with physical and heart transplants and, the CODA cast with deafness. And then, we have to recognize diversity in our patient population, but then also I'm sure that you want diversity in your healthcare team. And diversity in health care teams may be diversity in race, age, gender. Also, I would argue for diversity of ideas and life experiences. So you can see in the corner there, Michelle Obama hugging George W. Bush. And, they clearly have different ideologies, but they're still able to embrace each other's, literally embrace their differences. So I think that's really the epitome of inclusion and diversity. So I would argue that there are two driving factors for transplant disparities. One is that transplant remains a scarce resource, but it also has a very deep history of bias, which has led to mistrust of healthcare providers by patients and distrust of healthcare systems. And secondly, transplant's really demanding. So to have a great outcome, a family really needs to have a high level of organization. It helps to have social support and robust resources. We demand a lot of you with visits and testing and hospitalizations and medications, surgeries. It's just a lot to manage. So I want to go back to the history part a little bit. So the very first solid organ transplant that was successful was kidney, and that was December 23rd, 1954, between identical twins. And the recipient lived for 9 years, which was at that time really miraculous. But transplant between identical twins doesn't need to overcome immunological barriers, which we continue to struggle with now. And transplant remained a pretty scarce resource for a long time. And In 1962, a few years later, about 8 years later, this is a picture from the first dialysis unit for adults, and it was in Seattle, Washington. And you can see that these machines are enormous. They're almost as big as the beds, and they took up a lot of space, and there were limited beds. So with technology expanding, this was a great thing, but it was a limited resource. So how did physicians and healthcare teams decide who ended up receiving dialysis or transplant? The image I show you here is from a textbook from 1969, where they did a survey to ask 87 centers conditions which would definitely exclude selection of a patient for dialysis. And 68% of centers said that mental deficiency would be exclusionary, 29% poor family environment, 25% criminal record, indigency or poverty, 21%, poor employment, lack of transportation, lack of state residency. All these things are referred to as social determinants of health that are adverse. And so all these things were really impacting decisions about access to treatment. So with scientific advancement, challenges arose. Dialysis was expensive and scarce, and there was no funding. And so these death panels arose. They had to decide who lived, who received dialysis, and who didn't. And in Seattle in 1970, the executive committee at the hospital decided to begin to include children in these to provide access to this service for children under 16. Previously, it was not a service provided to children. So in order to decide, again, who would get dialysis or transplant, they said that a major consideration should be the family atmosphere and the determination of the parent that the child get well. So very much depending on social structure, family environment, social determinants of health. And of note, the committee members were very homogenous, mostly upper middle class, white, probably mostly men at the time, many male physicians. So it wasn't until the mid-1990s that candidates with significant developmental delay won legal rights to be transplanted. And even as late as 2004, there was a survey by the National Working Group on Disability and Transplantation that asked respondents who believed that people with disabilities were discriminated against in access to transplant. And 80% of respondents thought that there was discrimination. So there's an image problem with transplant, right? I love Joan Jett, but this is not a good reputation. So there has been improvement in the last 20 to 30 years. So in 1995, the American Society of Transplantation published guidelines that stated that we must ensure that recipient selection is not unduly influenced by outcome predictors of questionable value. And cognitive disability should only pose a contraindication to transplant when the disability is so severe that it precludes treatment compliance, which can't be compensated for by family or caregiver support. And the Canadian Society of Transplantation, about 10 years later in 2005, also said that cognitive or neurodevelopmental delay is not an absolute contraindication to kidney transplantation in children. I'm mostly giving you data on kidney transplantation because I am a nephrologist, but many of these themes and guidelines apply to all solid organ transplants for children. So transplant regulation. So in 1984, you may have heard of NOTA, the National Organ Transplant Act, that was passed by Congress in recognition of critical organ shortages and to promote efficient matching and placement. This act forbade organ trafficking and authorized the Department of Health and Human Services to regulate transplant. And it established what we know now as the OPTN and SRTR. It also, you may have heard of the final rule, and the Department of Health and Human Services final rule states that organ allocation shall not be based on the candidate's place of residence or place of listing. And the OPTN vision statement was recently revised. And if you go to the website, it says that the OPTN promotes long, healthy, and productive lives for persons with organ failure by promoting maximized organ supply, effective and safe care, organ allocation, and access to transplant, and does so by balancing competing goals in ways that are transparent, inclusive, and enhance public trust in the system. So how are we doing? There have been several recent reviews and some other research that I'll highlight in kidney about racial and ethnic disparities in pediatric liver and heart. A recent review in liver showed that disparities remain in pediatric liver transplantation across all points of the transplant process, from access to referral, likelihood of living donor transplantation, the use of exception scores, waitlist mortality, inequitable post-transplant outcomes. Black children are less likely to be petitioned for exception scores. They have higher waitlist mortality. They're less likely to receive a living donor liver transplant, have worse post-transplant outcomes versus white children. And children living in the most socioeconomically deprived neighborhoods also have worse outcomes and higher waitlist mortality and lower transplant rates. And distance also plays a role. Those who were further away were more disadvantaged from the further from the transplant center. Similarly, in heart, a recent study showed that variation in exception use across geography and demographics contributed to inequities in access to heart transplant for children, particularly those with low socioeconomic status. So in kidney, my research team has done several studies thinking about how allocation policies have impacted equitable access to transplant for children with end-stage kidney disease. A few years ago, in 2005, the allocation policy for children was called Share 35, and it preferentially allocated donors under 35 years of age to children. And this slide, figure A, access to transplant from waitlisting by race, white, Hispanic versus Black. And you can see here, the y-axis is the proportion of children still awaiting transplant. So lower is better. And the x-axis is time. And so white and Black children actually had similar waiting times, but Hispanic children were disadvantaged prior to Share 35, it looked like. And this was statistically significant. But after Share 35, then narrowing the difference actually was not significant anymore. So that's the good news. Children, regardless of race, had similar access to transplant. The bad news is that this curve actually went up. So it wasn't because we were doing a great job getting kids transplanted equally. It was everyone was waiting longer. So the white and Black children actually had longer waiting times after the policy. So things to think about when we look at differences and disparities. What's actually happening, and why are these curves getting more similar? We also identified geographic disparities in transplantation. So here we looked at organ supply demand and variations across donor service areas in waiting time. And the lightest color here represents the shortest waiting time, just 0 to 180 days, 6 months. And the darkest is more than 270 days, and then places where less than 50% of children were transplanted during the follow-up time. And you can see that here is a very light area with very short waiting time right next to a very dark area. So this is also what's observed in adults and across different organs. And so you can see this doesn't make any sense. If I live right on this line, do I have good access or bad access? And why should that make a difference? Also, we looked at living donation rates, and similar to what I stated about differences in liver, we analyzed nearly 20,000 children in our end-stage renal disease database, and we showed that living donation rates have declined over the last 20 years, and disparities persisted over time, with non-Hispanic white children receiving more living donors than other groups. Most donors are parents, and only 60% of living donations were from parent to child. There's increasing use of non-parent donors, which is great. But if you're in an environment with adverse social determinants of health, that may also impact the health of your parents. And so that can indirectly impact your living donor supply in terms of children. This was a study from Jill Chrisberg, who's a nephrologist now in Chicago, and she did this work during her fellowship training at Stanford, very similar to the work that we had done around the Share 35 policy. The kidney allocation system was put in place, I think, late 2014, and she looked to see if anything had changed with racial disparities during that time. And as you may remember, post Share 35, I showed you that the disparities in waiting times had declined, and she saw the same, that there were still no decline or no differences in time from activation to deceased donor transplant before or after implementation of KAS, which is great. She also showed that time on dialysis to transplant and the odds of short-term graft loss had improved after KAS. So this is good. So we see that there can be some positive effects of policy changes, but we do need to monitor them closely. So key themes so far. Transplant regulatory systems have arisen out of a long-standing history of scarcity of resources and medical decision-making that was really rooted in social worth assessments. Adverse social determinants of health play a major role in poor transplant access and outcomes. Where an individual lives can affect their health and their access. And common barriers include cultural, educational, health literacy, financial, and distance barriers. And allocation systems can be a tool to mitigate disparities. So now I just want to move on to talk about some strategies about sort of how we navigate this big transplant ecosystem and how do we achieve equity and inclusion. So this is a socio-ecological model of barriers to transplant, and it goes from the individual, which is, kind of historically, we're always saying, oh, that patient doesn't take their meds, or the family has this. I know you guys hear this as transplant families, right? You think we're all frustrated with you. But really, it's a much bigger problem than the individual patient. It's really, there are policies and infrastructure, healthcare system issues, lots of different barriers that get in the way of patients being able to do everything that we prescribe and ask them to do, everything that's demanded of a transplant to be successful. So first, I want to talk about the big policy level interventions and efforts. So the OPTN UNOS framework for organ distribution in 2018, which was kind of recent discussions, but even 4 years ago, the OPTN was sort of thinking about how do we make things better. And so they sort of created this graphic of the role of geographic distribution among other factors in organ allocation. And the components in allocation included medical urgency. So if someone has a high risk of death without transplant, they might be prioritized. In liver, this is a MELD, or for children, PELD score. Heart status stratifies patients by urgency. And then the geographic distribution that I mentioned in allocation systems traditionally have been donor service areas, and then regions and national distribution. And some organs now have concentric circles and proximity points, and this is ever changing. Also considering vulnerable populations like children and highly sensitized patients for whom it may be harder to have a compatible match. And then outcomes too, thinking about giving priority to the people who are really going to do the best, like perfect matches, zero antigen mismatches, and certain populations in the lung transplant population. So this is just a graphic showing you the DSAs. There are 57 donor service areas, which have traditionally been kind of our unit of organ distribution. And there are 11 regions across the United States. You can see that there are varying sizes and populations. And this is just, again, to use kidney as an example. The kidney allocation framework, KAS, is sort of now kind of out. But just for context, I just want to show you what it looked like. So it was an improvement over the old system in several ways. So it tried to stratify the quality of a donor organ with this kidney donor profile index. So the lower index was lower risk, so better outcomes expected. And then there were sequences within these categories of transplant quality. And children were prioritized locally, then regionally, then nationally, after patients who were highly sensitized, perfect matches, and prior living donors. And so you can see that you just kind of sort of fell into one branch. So if I was highly sensitized and a pediatric patient, I would be up here. If I was a pediatric patient and a prior living donor, or I guess that wouldn't be the case, but let's say a perfect match and a local pediatric, I would get extra points for the, I would be up here for the perfect match, but wouldn't necessarily get extra points for being a child within that perfect match category. And now it's essentially the same system as KAS, but instead of the organ distribution being by donor service area, it's now by 250-mile radius. So donor kidneys are offered first to candidates at transplant hospitals within 250 nautical miles of the donor hospital where the kidney was recovered. And then if there's no candidate within that circle, then it goes to the next outward circle. So version 2.0 is kind of what you're hearing about in the media and what we've probably sent you 100,000 emails about for public comment. This is trying to, instead of sort of lining people up, giving people weighted scores of priority based on more than one condition. So again, similar to that table that I showed you from 2018, this kind of throws out some key attributes or categories of medical urgency, post-transplant survival, candidate biology like blood type and sensitization, patient access. So again, vulnerable populations in here with pediatrics, patients who may need a kidney after another organ, waiting time, and placement efficiency too. You know, there may be a great candidate, but they're very far away, and that would compromise the quality of the organ. And so that is also, you know, some of these other things are considerations. So UNOS and the OPTN have done some prioritization exercises, and they asked for public comment feedback, which just closed a month ago. And they asked people, if you did the exercise, you had to kind of compare two things with a slide bar and report what you thought should be prioritized over another category. So this is just an example, but you can see medically urgent, extremely difficult to match, prior living donor, pediatrics, excellent prognosis for, you know, longevity, all these sorts of things. And so people could create a kind of a weighted score. How many points should you get if you fit into these categories? And the results are to be compiled and analyzed, and they're going to be provided to a working group. And then ultimately, you know, the committee, the kidney committee will decide. This has also happened in lung and is planned for other organs. And NOTA in the final rule will still govern policy development, but this is just a framework to inform how we weight the models. So is this good news or bad news for children getting solid organ transplants? And I would say it depends. So, you know, this is another graphic comparing equity and equality. So if the points for candidates are sufficient, then we'll have good access. If they are insufficient compared to, let's say, an adult that gets a maybe smaller amount of points, but over a larger magnitude of categories, then children may be at the back of they may be kind of over here and not be able to see the game. So we want to stay in the game. We want to be able to see what's going on. We want to be at the table. There will be a need to ascertain early data to see kind of what's going to happen with children after these weighted model results are in. And they'll have to do, I think OPTN and UNOS are planning to do some simulation models to see how this would actually work. But the community is really concerned because it's we're not sure exactly how that weighting is going to impact us yet. So strategies to optimize transplant access, again, at sort of that bigger policy national level, optimizing allocation, you know, UNOS and OPTN are really trying to do that, develop better infrastructure, And then other things that I didn't address too much today yet is, expanding the donor pool, mostly for adults, looking at different organs that may be previously considered marginal, but every organ that is added to an adult opens one up that may be able to go to a child. Also, living donor initiatives can help that piece as well. Preventive care, so making sure that children with adverse social determinants of health are obtaining their primary care visits, being seen early so that any disease can be caught early, and hopefully they have a longer time with health prior to end-stage organ disease. And then interventions to promote long-term graft survival, which may be everything from improving medication profiles to improving ways to support adherence if patients are having challenges. So all sorts of research and policy initiatives that can address this as well. So policy level, strategies are really, really needed. The supply still exceeds the demand. So over 106,000 patients need a life-saving transplant. That's the total wait list of candidates today. And over 61,000 are actively waiting. Among those, that includes nearly 2,000 children less than 18 years of age. And in 2021, we had the best year ever for UNOS and the OPTN, and over 40,000 transplants were performed, including in about 1,900 children. But 40,000 is a much smaller number than 100,000. So there's still a big difference in that, the supply and the demand. So we really have to be advocates and ensure that pediatric recipient and donor needs are being addressed. And that may include trips to Capitol Hill and lots of opportunities at UNOS. I want to move on a little bit to talk about healthcare system issues, and I'm going to kind of lump in healthcare system and community together. What can I do at my transplant center to ensure that I'm providing optimal, equitable care and reducing disparities for my patients? So Dr. Lefkowitz is a psychologist at my center, and she published best practices in the pediatric pre-transplant psychosocial evaluation. And she really advised that programs assist families to develop more consistent medication taking routines before transplant, that they self-monitor barriers that are interfering, and that they work with the psychologist to implement strategies to improve adherence before transplant. So really, the pre-transplant psychosocial evaluation should be a partnership between psychologists and social workers and families to set patients and families up for success. And this graphic is just showing you, one thing that we use sometimes in our clinic is the My Med Scheduler. There are different apps and things that can be used for reminder systems, but that's just one example. Dr. Lefkowitz also had some great suggestions to enhance the psychosocial evaluation. And a lot of them have to do with establishing rapport, being mindful of cultural differences, being very transparent, lots of things that really relate to inclusion and reductions in disparities. In terms of other organizational level strategies, so who is our team? So, is our team multicultural? Is everyone empowered to speak up, from social workers to, doctors to nurses, to child life therapists? And do patients and families feel seen and heard? Do they feel empowered, and do they feel connected and trust us? And there's definitely literature that suggests that patients with racial and cultural concordance with teams have greater trust. So if my patients and families feel like someone on my team looks like them or has similar life experience, that can really go a long way to enhancing confidence and trust. And that's super important for health outcomes. So a really amazing adolescent medicine physician that I've worked with, Dr. Sheila Quinn, interviewed 32 kidney transplant recipients at our center who had transferred from pediatric to adult care. And she wanted to know what were things that were associated with better transitions, stable function after transfer. And we all know that across organ groups, transitioning from pediatric to adult healthcare settings poses a risk for graft loss and rejection. And she hypothesized that some constructs of resilience would vary between groups, and that greater resilience would be associated with a more stable transfer. And resilience includes things like confidence, competence, connection. And she asked, patients about all of these things, these young adults, and she found the most two sort of striking things, I think. One is that stable patients had increased confidence in and connection with their healthcare team. So they really felt like they were partners in their healthcare decision making. And stable patients were also more likely to elicit support when they needed it. So they felt open and they were willing to be vulnerable and ask for help. And those two things were the two most striking features of patients who did well. We also interviewed one of our fellows who is now faculty in University of Michigan, interviewed patients who were undergoing transplant evaluation, caregivers, I'm sorry. And she interviewed 19 families and found that 40% of parents were working outside of the home for more than 40 hours a week while they were trying to navigate, all these appointments and demands of transplant evaluation. And more than half of our patients lived more than 50 miles away. And she made this cool word cloud of things that came up in the interviews. And the biggest word was overwhelmed, but some also said really hopeless and frustrated and anxious, stressed and uncertain. And this was really, concerning to us. We understand that the process is really scary, but it's sort of a call to us about, how can our team make this better? We also asked about financial burden. We recently conducted a study of parents and caregivers to see what sort of stress is caused by just financial expenses during the kidney transplant evaluation. And we asked 46 families. Over a third reported struggling to pay living and medical expenses. And the top 3 direct stressors where patients or participants had to rank things from 0 to 10, 10 being the highest. And things like paying for travel and to and from appointments, paying for food, nutritional supplements, paying for housing while a child is hospitalized. All those things were really stressful for our families. So how do we use this information? We have to invest in initiatives and have our team members improve education and support families. So we've included a living donor educator in our team because that was a big area of uncertainty and sort of lack of clarity about kind of why we can only tell them certain things when the living donor candidates are being evaluated at the adult hospital. Families asked for like a Facebook type picture of our team to know who's who and describe the roles, and we've been working on that. We really have to engage patients and families in the process. So in our center, we learned a lot by doing these surveys and these interviews, and that was one way. In many places, they have patients and families on advisory councils. We have that as well for our general hospital. We started a vaccine clinic to reduce some of the barriers associated with having to go to the primary care doctor for vaccines during evaluations. We really try to optimize our language services and interpreters. We've been looking into, opportunities to work with community health workers. Some of our other chronic disease populations have used community health workers with great success. And certainly with the pandemic, we've optimized telehealth visits to reduce travel burden and done some transplant evaluations that way. And then when we apply these things, though, I would say that we have to test their effectiveness and their cost savings, because in order for transplant families to have lower financial burden, we really need to show insurers that these efforts and these investments are cost saving. So now I want to move to the individual level, which patients and families are at the center of everything. But I would say I have 2 tips for our patients and families who are missing or are listening today. Number one is to vote and to be engaged, whether it's a local election, national election, whatever it is. Be aware of the issues related to healthcare reimbursement and take a vote. And the other is to be at the table. So I mentioned that, over 100,000 people are waiting, but only about 2,000 for an organ, but only about 2,000 of those are children. So we make up a really, really small population of the big pie. And if we're not at the table, we're not going to be necessarily considered. So there are many opportunities. UNOS asks for public comment. There are opportunities to serve on committees. There are regional meetings. Many of those are now remote or virtual, so you can just, pop in and out as needed. I would encourage transplant families to engage in patient and family networks. I know there are lots of collaboratives out there by organ, and engage in hospital patient and family advisory councils, as I mentioned earlier. Tip number 2 is be vulnerable. I know it's really hard and transplant is so complicated, but we don't know what's going on unless you tell us. And as I showed you with Dr. Quinn's study, the patients who did the best were those who were willing to ask for help. This graphic is a picture of a CVS pharmacy that was shut down during some racial riots in Philadelphia. And one of my patients got his immunosuppressive medications here, and he couldn't access his medications because the pharmacy was no longer open. And so we were able to help him navigate and figure out where he could go to get his meds. But had he not told us, he could have run out of meds and risked rejection and graft loss. And if you don't feel like you're being heard by your centers or your teams, most children's hospitals and transplant centers do have family advocacy services, and I would encourage you to use them. I mean, obviously, hopefully you're comfortable speaking with the team directly first, but if you really don't feel like you're being heard, then there are always avenues to escalate. So in conclusion, I would say that disparities in transplant access and outcomes are not the problem of individual children, but rather of this sort of messy ecosystem of policies and health services that serve those individuals. And strategies to mitigate disparities really have to be policy and system level focused to enhance the patient and family experience, to improve transplant access and outcomes, and to reduce the burdens of chronic illness and transplantation in particular. And I thank you, though. I just want to end with this great quote from the World Kidney Day Steering Committee from 2012. Transplantation is an essential, viable, cost-effective, and life-saving therapy, which should be equally available to all people in need. Thank you.
Thank you, Dr. Amaral. Tawanna Williams, who did our intro, unfortunately is having some audio issues, as you guys know, but we have some questions, and I thought we would try that first, and then maybe we can get her stuff back on. So the first question we have is, do you have thoughts on how to encourage marginalized communities to engage, given that their marginalized status makes engagement more difficult?
That's a great question. So I think, again, part of it is making sure that our teams are diverse. And I know at CHOP, for example, we have a pretty robust LGBTQ community, both with staff and workers who do outreach and try to make that population feel less marginalized. And it's, some things are simple, like staff education. Some things are very, we all have our badges and our IDs, and we've been given rainbow ribbons and adding pronouns to our badges, and things that sort of normalize difference within our culture. I think that's sort of, again, I'm very health system focused and kind of what we can do on a bigger picture. I think we do have community partnerships as well. And so making things that are culturally sensitive, maybe making sure that we have staff who speak different languages, or interpreters that can also sort of share, explain, cultural health beliefs and things like that, those sorts of things. But I think people tend to speak up more if they feel comfortable and accepted. And so creating that kind of environment in the healthcare system, I think, is one way to approach it.
The question, I think you kind of already answered it before after this came in, but I think it's important for people to remember is what are ways to respectfully advocate for yourself in situations where you feel not seen or discriminated against?
Yeah, I think, so, I did mention, hopefully there's somebody on the team. Our transplant teams are pretty big. And I know that sometimes, we all have different personalities. In my practice, there are 14 physicians and we're all a little different. We have several nurses and social workers. And sometimes you just aren't communicating clearly, or you're having challenges with a particular individual. And I think in that case, then I would try to find an advocate on the team, someone that you do feel more comfortable with. It's obviously harder if it's not a diverse team or if you don't feel trusted. And I would say if it's across the board that way, that there's no one on the team that you feel like you can trust, then I would actually encourage you to get a second opinion, go to another team, go to another place and see, because it's so important. Like, I mentioned the vulnerability aspect is actually a really important part of achieving optimal health outcomes. And so if you don't feel that you can be vulnerable with your provider, then I think that maybe you need to find somebody who is, sometimes it's the primary care doctor too, but, I know a lot of our patients see us as their main doctors. And so I think that that's something that's achievable. And, if you're not comfortable talking to your point person, then maybe ask other transplant families on this, conference, where they might recommend that you go, where you can get the care you need.
I'm a kidney mom with a kidney transplant, and we definitely use our nephrology team sometimes as a primary care team. So I definitely relate to that. I think the other thing you brought up was family advocacy. Usually there's a patient advocate or a department within hospitals, and but I do love the fact that you should talk to your team first, but there's always that route to go as well. The last question I have is, what are times when we can speak up and help bring awareness to equity issues?
I think there are, as I mentioned, a lot of opportunities with UNOS, actually. We have quarterly regional meetings. We have, there are different committees. There's a minority affairs committee. There's a patient affairs committee, ethics committee. There are lots of different committees where they're actually really looking for a diverse stakeholder participation. And so that's an opportunity. If that's sort of too much, the regional meetings are a little bit easier. They're not as much time burden because, like I said, you can just kind of log in virtually. Putting in public comment about your life experience is really important. There are a lot of collaboratives, like for kidney, we have IROC, Improving Renal Outcomes. I know there are several for, here. And getting the word out. A lot of hospitals too, like, for CHOP, for this transplant week, we've been highlighting patient stories. And I think sharing your life experience and making, I'm trying to make sure too that, like, are we reflecting our diverse population and having different stories and things like that? So I think in those ways, and then there are other ways, like, if something's really bothering you, you feel like it's unfair and you want people to know about it. You can, people do leverage social media. You could do an editorial for, a newspaper or an article, depending on your level of motivation. I think definitely get it out there, whatever it is, and you can partner too. Like if you're, worried that something sounds too, I don't know, whatever, see if somebody on your healthcare team would partner with you, or another parent would partner with you. Your voice really, really matters. And again, like, I can't reiterate enough there are so many adult transplant candidates on the waiting list, over 100,000, and only 2,000 kids are on the waiting list. So we're such a small, part of that bigger thing. And so all these discussions often really focus on what the needs of adults are. And if we're not at the table, if we're not saying, hey, this doesn't apply to our patients, this doesn't apply to my life, how am I going to work and get childcare for my other person while I'm, other children while I'm doing transplant evaluation? If people don't know it's a problem, they don't know to look for a solution.
Right. I have a kidney transplant daughter, but I also have a daughter where she also has a disability with her having a stroke. And I think about how inaccessible the world is in that inclusion way, right? So when we talk about inclusion, we're talking about race, but we're also talking about disability sometimes. And one of the things transplant families and a lot of our pediatric transplant organizations have been working on at the federal level is a bill to not discriminate against organ transplantation for disability. And then we have a lot of states that don't allow that, but it's not, there are states that do allow that. So it's, those national policy issues or the state policy issues can really come into play.
Yeah, I would totally agree. I go to Capitol Hill a couple times a year. Before pandemic, it used to be in person, but occasionally I'll try to take a patient, and because, you know, our congressmen and legislators will really listen to you more than me. You know, they want to know what their constituency is experiencing, and that's how you can kind of shift votes and legislation. There's also current legislation to improve access to mental health care for children, which is so critical for our children with chronic illness and solid organ transplantation, and also to improve broadband access so that we can everybody can get telehealth regardless of their social determinants. So that's another thing. So you really can make a lot of impact, even, you know, calling your senators and representatives when different things come up. That's also another way to be highly effective.
Right. And remember, I always think, because I run a pediatric organization, is for transplant is like, oh, our voice, we're so small. We hear sometimes, oh, it's such a small part of the population, but those policy changes can impact our kids. And we need to make sure that we're thinking about how does that impact pediatrics. Thank you for your time today. You know, we were hopeful that Tawanna was able to record what she had to say and to get sent in, but it doesn't look like that's working. Her Wi-Fi isn't behaving for her. On tech checks it did. But I do want to acknowledge that she has some powerful stories to share. We're going to edit them into this video when we put it on YouTube. But just for those that couldn't hear at the beginning, she is the owner and lead consultant for Race Equity Solutions. She's also a mom of a heart transplant kid. And then she's part of the Diversity, Equity, and Inclusion Co-Chair, Medical Advisory Council, and a volunteer director for the Children's Heart Foundation. Sounds like she's very busy. So please, after this session, do replay this. It's such an important part of our community, and we all need to work together to make sure that it's more equitable and inclusive for everybody. So I appreciate you guys being here. We do have a trivia question. Let's see. What was our trivia question? 60% of patients awaiting life-saving transplant are minorities. True or false? So that's not for you. That's for the chat. They can win a prize. So put your answer in the first person to say. I guess it's 50-50. 2 people will win a door prize. Anything else to add before we close? All right. Well, thank you for being here, and we'll see you in the next sessions.
Hi, I'm Tawanna Williams. I'm here to speak a little bit about the intersection between disparities, healthcare disparities, data, and lived experience. I'm qualified to do this work in several different ways, largely though by experience. My lived experience, as a Black woman, and what I sometimes refer to as a double minority, because with the intersectionality of being Black and being a woman, I've seen it all. But I'm also qualified by education. When it comes to systemic and institutional racism, I've done my research and I've looked at ways to eradicate it, and I've become certified in diversity, equity, and inclusion. And I'm also a heart and transplant mama, which is why I'm here speaking with transplant families today. My daughter, Avery Grace, was born with hypoplastic left heart syndrome, so that's HLHS is what we call it. And she received her gift of life and her transplant just before her 3rd birthday, about 7 weeks before. But Avery Grace was in heart failure by 7 months old and had already went through 3 open heart surgeries for a culmination of 6 total open heart surgeries in her first 2 years of life. So you could say that we've been around the block in the heart world and in the transplant world, and through that experience, came my lived experience of healthcare disparities and living as a minority family within the healthcare system and all of the pitfalls that that could entail. So initially, I had plans to speak about something completely different. A couple of things happened over the past week, though, that led me to scrap my presentation entirely. And what you'll be receiving today is simply me speaking from the heart with words that I jotted down relatively short time ago, but it does have my background education, right, and my lived experience as the foundation for what I'm going to tell you today. So one of the events that caused me to go left was a call out for others' lived experience with discrimination within the healthcare system. I have shared my story extensively on other platforms, and so it didn't feel right to reiterate that today, although I am welcome to answer questions from anyone at any time. But what you'll be receiving today is simply, me being a little bit taken aback that some individuals didn't want to share. We knew these experiences existed though, right? And me as a DEI professional, I respect privacy and I respect that these experiences are raw, and I respect the fear that can sometimes accompany it. And so I shouldn't have been taken aback. And it was a little funny though, right? Because we heard crickets when we put out that call. We didn't get the stories that we knew existed within our transplant families community. And there are reasons for that we are going to get into shortly. Very few spoke up. And as a private person myself, in some respects, I completely get it. As a DEI professional, I completely get it, because sometimes keeping things close to our vests feels right, and it's our right. And, I am personally at odds as a Zennial, right, with our share social media culture. And I've always held Avery Grace's story kind of close to the vest on public, on public forums. And so I get that, right? But it's also important to recognize the power behind silence. Silence has weight. Silence bars us from speaking up, telling our truth, setting boundaries, or having demands. Silence can cause things, to fester from within. I know this from experience. And in this case, silence is the enemy of the change that we so desperately need and we so desperately seek. These individuals did not feel comfortable sharing their stories, even anonymously. And that's okay. What that did tell me, however, what it informed me, is that we failed to provide an emotionally and psychologically safe space for people to share, and how much work we have to do, right? We've got so much work to do. So that's the first step. How can you and we, within our respective organizations and lives, provide a safe space for individuals to share? This looks like climate surveys and employee resource groups, DEI professionals, and informed and concerned clinicians. But I'm here today to tell you that there is a greater power in your voice than there is in your silence. I'm going to repeat that again for you. There's greater power in your voice than there is in your silence, in all things, but especially here, in this space, in this intersectionality that I'm speaking of today. I'm going to share a few of the brief stories that were shared with us, and I'm going to read them so that I can make sure they are in the individual's words and not in my own. One parent of color is a nurse at the same hospital her child is treated at. She intentionally failed to disclose this during an ER visit. She noticed a distinct difference in treatment. This individual felt like she was talked at rather than spoken with during clinic visits. Oftentimes, practitioners would give her updates, yet forget to ask for any updates that she may have, and would quickly give her the next appointment date for her child, so she felt as if she was being rushed through. She was not considered a part of her child's care team and felt as if there was not an opportunity for her to contribute, and as if they assumed that she would have nothing of value to add. She really appreciates her doctors and nurses, but she felt hurt when she consistently saw other families being listened to in a more active way. She didn't want to say anything for fear of ruining the medical relationship and perhaps affect the care for her child. And the next parent felt that when she came into clinic with her two young children, and they were rowdy, as sometimes our children are, right? Despite her best efforts, sometimes our children are rowdy. And so she would get looks, and she was questioned by the staff if she was capable of keeping her kids under control. This parent noticed other families that were not of color, with children exhibiting the same behaviors, yet not getting the same admonishments as she was. And the last parent is of Latina descent. She was initially a Spanish-only speaker when her child began her treatment journey. She states that practitioners would sometimes speak loudly to her when she struggled to communicate, as if that would help her to understand English more than she currently did. And this parent wishes the staff would understand that she was desperately trying to learn the language, and that more clinicians, were bilingual or had bilingual support staff. And in her case, in all of our cases really, representation matters a great, great deal. It's imperative that she understand the treatment options for her child, and she shouldn't be made to feel as if she is less than because she is not a native English speaker. She feels a great sense of relief when a Spanish-speaking member of the team is present, and she realizes that not everyone can speak Spanish, and so she's in awe of the work of her team accomplishes despite language barriers. Yet she cannot say that she feels empowered as a parent or a part of the team for her child. She hopes for more compassion for those staff that aren't a part of her immediate team, as she starts at a face value that's riddled with bias with each new provider or group that she meets. So I want to share that each of these individuals were very, very quick to add the disclaimer that they love their team. They love their center and they love their team. And that's great, right? Like, we should all love our teams. And if we don't, as a little aside, I encourage you to seek treatment elsewhere, because we are empowered and duty bound to make the choice for the best care for ourselves and our loved ones. So they love their teams, and it's fantastic. And yet, who taught us that our truth must be accompanied by a disclaimer? As minorities, myself included, who taught us that we have to preface our truth with a compliment as if to deflect from our issue, right? Your truth does not require a disclaimer, ever. Two things can be true. I say this in my life all the time. Things can exist in duality. Your care team can be a great one, and you can experience institutional racism, have to be alert for healthcare disparities, and be a victim of bias, whether it be unconscious or otherwise. Dr. Amaral did a fantastic presentation for us where she shared a lot of disparities and offered a lot of education on equity and inclusion and how it relates to transplant patients. And so now it's time for me to talk about how those disparities that led to the carefully curated data and presentation manifest in real time in real life for families. If you're a transplant family, you're accustomed to advocating because you do not get this far, right, without a tumultuous road, period. No matter when it happened or how it happened, none of it was easy, and we experienced things that no one should ever have to. And I sigh because with that comes weight and a change to our consciousness and way of life that I don't even begin to have time, to address today in this forum. But what I will take time to address is how unjust it is for families of color and other differences to have to advocate on behalf of their race and nationality as they go through these life-altering experiences that lead to transplant. There's nothing more draining than having to consistently prove yourself and earn fair, equitable medical treatment time and time again, as if you feel like your life's falling apart. You're called to do this. But we know that life isn't fair. People who walk in our shoes know this intimately. Some things just are. And this is one of them. But not if you don't speak up. Things can be changed. This is one of them, but not if you don't speak up. Nothing will change unless you do. Nothing changes if you don't set boundaries or ask and demand when necessary. There are clinicians who have had to grapple with systemic and institutional racism as they gain their education and went on to find employment. They deal with the effects of unconscious bias daily. And there are families who never feel comfortable in their skin when receiving treatment and who are ever aware of the healthcare disparities that dictate that they or their family member may not receive equitable treatment. And we've seen failure to rescue rates, and we've seen that this can be the difference between life and death. And so there are those of us that have that weight, this weight to carry, of this along with everything else that we're carrying and daily, right? In and out of the hospital, we are, in the medical system, we're living with oppression and injustice and fear. So with all of that, here's the action step. What can you do, right? What can we do? Things are this way, and what can we do? This is when you use your voice. You speak up, you educate yourself, and you escalate within your hospital system. The clinicians could not do their job without us. We need them, they need us. Patients and family have choices. We have choices that we're not always exercising. And with choices come power. So yes, there's power in silence, but the power of your voice, right, is louder than the power of your silence. and the power of speaking up and making a choice to perhaps leave a team or a center because you're not getting equitable treatment, there's power in that too. There's power in action. So if you fear your treatment isn't equitable, don't convince yourself that you're crazy or being aggressive or angry. Trust your gut and what you know to be true, because largely we know when we are receiving equitable treatment, and the absence of it, feels even larger and it resonates even louder within our souls. You're likely right. And that little voice deserves consideration. It deserves consideration from you and from the patient advocacy team within the hospital, because every hospital has one. And I think that sometimes we're just not equipped with them. Transition your medical practices where it's possible as you see fit as a last resort, but if you need to. Now, we all have been through this and we know that centers matter, and we probably know off the top of our head the top 10 centers every year when they're released for our specific area of transplant, right? But centers matter, but so do the systems within those centers. And the ranking of the center won't matter as much if you aren't receiving equitable care. So to clinicians, I ask that you check yourselves of bias and your colleagues and others. Work from within, be alert and be on watch. Educate yourself and educate others. Be our voice in the room and at the table when we're not there. Don't satisfy yourselves, any of us, with diverse marketing campaigns for our hospital systems or our doctor's offices, brief trainings that don't result in action, TED Talk type speeches that sound fantastic, and these anti-racist books that they pass out, and then do nothing. There's no culture shift. What happens next? What happens after that? Is a climate survey being done? And are they taking action steps based on that, right? Do employee resource groups exist? Is there a hiring pipeline in place that eradicates societal hierarchies and makes a distinct effort to hire diverse staff because representation matters? Are you intentionally clearing your mind, clinicians, of preconceived notions and meeting each patient and family with a clear outlook? What do we do with this disparities data? And is it top of mind when we see our patients? Are you reporting when you witness behavior that isn't equitable? Are you a part of creating an equitable and inclusive environment? Big questions. So I'm going to leave you with this. It is a big task. Most things worth taking on are. That's life, right? Transplant was a big task, and aren't we so grateful for the gift of life for our children and for ourselves? So it's a big task, but it's not an impossible one. It's necessary. It's big and it's necessary. Complaints without voice or action do nothing but breed stagnancy. Your voice is your power. So that's where you start. You start with your voice, with yourself, in your own backyard. Be vocal early and be vocal often. Share your experiences, ask questions, offer ideas, report, and demand the change we all seek to help ensure that health disparities become a thing of the past. There was a campaign a long time ago, and I'll date myself, and I don't remember what it was for, but it said, if you see something, say something. So if you see or feel something as a family or as a clinician, I urge you to say something. Once, twice, and again, as often as you need, because nothing will change unless we do, right? We've got to do the work on our own, and we've got to make our voices known. Become a thorn in their side and create what doesn't exist. I will repeat. If you see something, say something. You have power in your voice. That's greater than the power of silence. And the power of your voice can create actions that help to make a difference in systemic and institutional racism, especially if collectively we all do this within our respective centers and band together. Believe in the power that got you this far for your family, right? Believe in that tenacity and that hope and that faith and that action that you put behind transplant life, and put that same thing into getting equitable treatment and care for all. And I'm Tawanna Williams, proud mom of Avery Grace, who will have her 3rd transplant anniversary, heart anniversary, on May 3rd. Thank you.